Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma, COVID update. So I was pretty annoyed last Friday, and because I was annoyed, I was a little strident, and it made a lot of people happy, but a few people just don't understand stuff. So I'm going to make it clear. So for anyone who keeps on bringing up who's new, why would a gynecologist, why would you ever listen to a gynecologist? It's not about whether you're a gynecologist or whatever. It's like if you have knowledge or training. So for those of you who make those comments, which just, I don't know how many times I'm going to have to tell this because I don't want to have to go over this over and over because whatever. But I was in the public health service. I was formally trained in infectious disease prevention. Okay. I wrote the policy paper for the FDA and CDC initially on preventing HIV spread in a hospital setting. It was my policy paper. I wrote it. I had mentors, but I wrote the initial policy paper for preventing spread of HIV in all hospitalized and clinic settings. It was a huge project. I had lots of help, but I had tremendous training. And so I have a background in infectious disease. I've always had an interest in infectious disease, and I had formal training in it. So that's why I'm interested in it and will always be interested in it, which is why I've led things in this area. Number two, who's running the Central Oklahoma COVID task force for essentially 2 million people and coordinating 5 major hospital systems? A gynecologist, a neonatologist, a gastroenterologist, and an internist, okay? Now, the gastroenterologist is chief of population medicine at one institution. The neonatologist did get a master's in public health, but oh my God, she's a neonatologist, a brilliant one, as is the GI doctor. And then the internist is fully trained hospital administrator, internal medicine physician who knows more about how policies work in hospital to get things done than almost anyone I ever met in my life. But yeah, no, we're not infectious disease experts, nor do we need to be. We can read and we can handle things and we know how to develop systems. And that's why the Central Oklahoma COVID response has been the leader in the state. It's why we've been asked by the state health people multiple times to potentially take over the whole state, which we've said no to because we have to focus on our own. But no, people can be trained. So now we're going to go to statistics because some people didn't follow the statistics I said. And so I'll try to keep this really, really easy, but these are not always easy subjects. So let's talk about herd immunity. Herd immunity is there's enough of us who are infected or vaccinated or exposed, so we've had an immune response to an antigen, whether it's a virus or whatever, that we won't continue to get infected, so we can't spread it to others. So that is a key concept, herd immunity. Herd immunity could be opposed only from a vaccine. It could be composed from vaccines and infections. It could just be from infections. So for years and years and years, chickenpox, herd immunity, didn't exist in young people. It only existed in older people because everyone got it. And once they got it, they became immune. So now we have a vaccine for chickenpox. So what's the deal with COVID? So there's first some discrepancies. The first discrepancy, and this is why I get frustrated with Fauci, and I won't be as emotional about it, I'll just be scientific. He ignores 100 years of immunologic data on viral infections. All the data shows universally that an infection is much more potent against a recurrent infection than a vaccine. That's a general statement, but it's pretty much true. It's pretty much true universally. We have to acknowledge that. Beatty Stradler, really argumentatively, the number one immunologist in the world, has written many commentaries, put papers together, documenting that the studies show that 30% of the populations of the world across different countries, and so a blended average, have cross immunity against COVID, meaning it's really hard for them to get infected from it because of corona cold virus prior infections. 30% of people, it appears in other data sets, have cross immunity who have an active measles, mumps, and rubella vaccine, which a large proportion of at least Americans do. So now let's start looking at the numbers. So herd immunity is infected. It's infected. It's not just vaccinated. The infected people have high antibodies. If you will look back on my January 17th post, you will see a very easily understood graph that shows the orange dots who were previously infected people skyrocket their antibodies much higher than those who haven't been infected with just one vaccine, and the people with just one vaccine who had had the infection, those antibodies go higher than anybody else's who've had 2 vaccines. And the whole point is, no, they're immune. They're immune. You have to understand immunity, which again, why I get frustrated with Fauci. And it's not because I'm a right-winger. I am a truth person. I hate liars. He's lied, and he continues to lie. So it makes me frustrated because he is, I think, fundamentally responsible for the disaster of COVID in the United States. But be that as it may, the bottom line is we know that roughly 100 million Americans by serologic testing have gotten COVID. So, okay, that means 100 million, okay? So then we expect 130 million to be vaccinated by March 30th. That's 230 million people. So now let's think how many people are in the United States, about 330 million. So 230 million vaccinated people, because 95% of us get immunity. So we'll say 205% of 220, I don't know, 5 million, let's say, or 10 million. So 210 million people. So roughly about 64% immunity rate. We also then leaves, so for the gentleman who said I mixed my cross immunity stuff, no, I didn't. Give me a break. I wouldn't make that kind of error. So that leaves about 120 million people left. 30% of them, roughly, are going to have some cross immunity from coronavirus. So that's 30 million. 30% are going to have some cross immunity against measles, mumps, and rubella. Let's just make it 10%. So it's going to be 8 or 10 million of those left. So that puts us well above the 70% threshold. So when you look at herd immunity, how do you figure it out? It is 1 minus R-naught, 1 minus 1, with 1 being the numerator, and the denominator is R-naught, 1 minus the R-naught. So blah, blah, blah. Sorry, I did that wrong. So it's 1 minus 1 over the R-naught. So R-naught's the number of people infected. So let's make this easy. Let's say the average person with COVID infects 2 people, okay? That's the number of people they infect. So you would take 1 minus 1 over 2, or a half, and that would give you a half, or 50%. It would take 50% of the population to be either vaccinated or previously infected for a herd immunity. There's a big debate with COVID what the R-naught is. It's somewhere probably around 2 to 2.5. So if it's 2.5, roughly that's 70%. So all the biggest scientists and statisticians in the world think the average right now is somewhere in that range. There's some Swedish people who think, scientists who think it's much less. There's other people who think it's a little more. But the bottom line is this: the case numbers falling dramatically during the most infectious time of the year for the virus, and when it boomed last time. Why? Because there's developing immunity as the primary intervention. So it's going to slow the virus down. If we continue on the vaccination pace we're on, we are going to be in fabulous shape April 1st, because we have to count the cross immunity people, which is we're only counting the cross immunity people who haven't been infected or vaccinated. So it's just basic statistics. Sorry, it's not that exciting stuff. And it's the reason I get frustrated about it, is because if I can do this, who I don't spend my full time doing this, the people who are being paid by us, because they're not doing us a favor, should be doing this correctly. Why did we have to have Dr. Markary from Johns Hopkins School of Epidemiology write that? And in his own paper, or his publication in the Wall Street Journal, this story, he said he was pressured not to put this out for various reasons from his own colleagues, not because it was truthful, but not to change the narrative or not to potentially impact immune rates. Stop with this lying stuff. Stop. So even if you don't like me and you're frustrated with me, how about this isn't political. This facts. This is a fact. Fauci lied about masks the first time. Okay. And he went back and said, well, it's because I didn't want people to use them, the PPP all up. That was the single most destructive thing he could have done. Let's be honest. And then he lies again where we need 2 masks. We don't need 2 masks. There's no data supporting that. The CDC won't even publish the data they made up about it. They won't give you what the reduction is if you just wear 1. We already know it's 85%. And 2, they said is 95, but it's not a comparative study, and they didn't do it or publish it or do anything like that. Plus, it's sometimes I wonder if they even understand the new data that shows that how do masks actually work. It's just by blocking them from here to here, the humidity goes up, it kills the virus. So masks work, but they actually work through humidity. It's really kind of interesting and cool. But the point is 1 mask's enough. That's the science. We don't need 2. It's baloney. The constant baloney drives me insane. Just like Fauci's saying today. And Fauci's part and participle of this problem. So again, I don't know how to avoid this subject when these mistakes that we're going to have to wear masks till 2022. No, we won't. Only if it's about keeping us locked into this fear about COVID. COVID is something we have to learn to deal with. We need to be able to look at each other. We need to be able to communicate. Those of you who don't think that's important, look at the suicide rates in teenagers. Just look at them in the early 20s. Just look at them. Actually take the time to study them. And then you'll think, well, maybe this isn't such a great idea. And think about all the spousal abuse, all the child abuse, the massive uptick in hepatic cirrhosis that we're seeing in Oklahoma City. And I know it's universal from talking to these doctors who deal with this, because people are not dealing with this well. But we can live in a shelter the rest of our lives because there's a virus that is easily treated, I think, with nutrition, and B, there's a great vaccine. And for those of you who don't believe there's a great vaccine, hey, I've criticized a lot of what they've done on a governmental level, but the vaccine from Pfizer and Moderna look great. The data looks fantastic. There's not this huge amount of disastrous stuff occurring. It's very, very minor. And if you look at the COVID patients I take care of, which I had 3 COVID long haulers this afternoon on the phone for video medicine conferences or medicine, they're not doing well, even with everything we're trying to help them with. And that is tens of thousands of patients in the United States, probably hundreds of thousands at this point. And it is a bummer. And so we don't want our people to get COVID. So that's why we want people to get vaccinated, because COVID does kill people. COVID does give a lot of long-term side effects. And the actual death rate in hospitalized people goes up by a massive amount once they leave the hospital relative to the initial group, because there's so much longer-term morbidity and mortality from the disease. So again, the point is, people can know stuff. They can read, they can educate. Because remember, I've always says, at Ohio State, we were trained to be doctors. We weren't trained to be X. We were always going to be a doctor first. You're a doctor. You handle medical problems. You may have a subspecialty, but you can read and you always have to think. And maybe that's why I was a philosophy major and I can think. And maybe that's why some people get frustrated with some providers. They don't think, but I can think. And so I'm going to address COVID, how it is. And for the most part, I haven't been wrong yet, other than saying that Trump was going to shut the country down at 50,000 infections, which I still think he should have done. Right or wrong, if you disagree with me, that's fine. He didn't do it, so it doesn't matter. But other than that, I've been completely correct, and completely correct first almost every single time. So, sorry. Anyway, that's not to be mean or anything, but I mean, criticize me for being wrong about stuff. I haven't been wrong about anything about the hardcore science on COVID. Okay. Oh, and there is a 4th reinfection documented now, because I'm keeping track. So a 4th reinfection, I just saw it today from last week on a South African variant in France, made it into the publications. So again, we're at 4 documented reinfections. Are there more than that? Absolutely, positively. Figure there's about a 1% rate for reinfections. There usually are, but it's not because of the variants, it's because some of us just don't make great immune responses to any virus. So we can get reinfected with any of them. It's not unique. These people, it's not unique to COVID. There will be one-offs here and there, but again, the reinfection thing is very minor and not important. Any questions, honey, or am I good?
I have questions.
Oh, we'll do some.
Okay. So Back on the masks,
Mhm.
where you talk about the humidity, what about when initially they were saying we wear them because it's protective for others? Is that true? Is it both?
It's probably a little bit of both. I think I would go with at this point, it's both. I think obviously if you have a mask on and you sneeze and you have COVID, it's not going to spread as much. But the other part is it's definitely the humidity is what it looks like.
Okay. How long is too long to wait for the second vaccine since
There,
people are having troubles?
how long is too long to wait for the second vaccine? It's never too long. It's always going to boost your immune system. I mean, if you look at the data, again, you have to look at the data. Look at the phase 2 data on the Pfizer and Moderna. Everybody has a brisk, almost every single person has a brisk immune response. If you're under 55, it was 95%. If you're over 55, it was close to 95%. So the second vaccine really isn't that important for any of those people anyway. So as an add-on, it's going to raise your antibodies again. Look at the January 17th paper, but the antibody levels are way high for the vast majority of the patients, and that is going to last for a while. And the other question is how long? I mean, you would think minimally 4 to 6 years, minimally. I was looking at all the vaccination data and how long immunity lasts. The shortest is 4 to 6 for almost any vaccines, and most vaccines are longer.
Are you concerned about the spike protein crossing the blood brain barrier in mice?
No, but it's because the spike protein, the thing you have to understand is if you're giving a messenger RNA vaccine or you get a messenger RNA virus, it is going to be eventually, as it's spreading, in a lipid bubble. Lipid bubbles cross the blood-brain barrier, which I'm sure everybody knew that already. But sorry, couldn't help it. For the people who think that sometimes I don't know what I'm talking about. No, they cross the blood-brain barrier. So viruses get into the brain too. That's why people get encephalitis or meningitis and things from viruses. It's a bummer. But this is a spike protein. It's to get an antibody response. I'm not worried about it. Maybe I know, again, I could be wrong later because we don't know the long-term effects of the vaccine, but that's also why I don't think we should be giving it to kids or people much under 25 to 30 unless they have major risk factors, because they're not going to get sick from COVID for the most part, and if they're taking vitamins and doing normal stuff, they're going to be fine.
Was the cycle threshold of testing lowered as suggested by the WHO?
I mean, that's an interesting question. I don't think we'll ever know the answer to that because again, I don't want to criticize the WHO because that is a mandatory strike against me on Facebook. So I don't know if they did or did not. I don't think it in the end matters. I think the proof's in the pudding for how many people have gotten COVID and died in the United States and the world. If you're a medical professional who's actually working in either general care or pretty much any part of care, you've been affected by COVID. You've had patients get sick with COVID. You've had patients die with COVID, or friends, or both. So I don't think any of us believe it's a made-up disease. And it didn't. And again, COVID did not go away after the election, which everyone said. If anything, it got worse. And so there's parts of it that have been lies the whole time. But COVID is a very serious disease and not something we want to get, which is why I think we need to rejoice that we're this close to herd immunity.
How do we know that the immunity that we're seeing, how do we know that that's going to be long term, like with the Spanish flu versus immunity with the common cold that we can get over and over?
Well, I think we don't know for sure yet, but we do know that the preliminary data out of China is the SARS one patients did not seem to get COVID. Number two, we know that this is a rather unique mutation, so I think we're going to have some pretty good immunity from it. But no, there'll be a time where we get variants that we're going to have to deal with. But again, the natural course of viruses is to lessen their intensity after a big pandemic. I mean, Spanish flu occurred. They still had immunity in 2008, the ones people who were alive who got it, to Spanish flu. So unless there's a huge mutation on the spike protein, they're fine. And remember, as these viruses mutate, their intensity changes. So what I talked about before with the spike protein mutations with, like, I think it was the South African, if the spikes like this, some of the antigens changed here, which opened up previous non-neutralizing antibodies that the body made against the spike became neutralizing on the South African variant. So again, it's a mixed bag. It's not doom and gloom. That's the whole thing. We've had tens of thousands, millions of viruses, and we're still here. This one is not going to destroy us. We don't need to wear masks the rest of our lives. We don't need to be impotent in terms of thinking. We can survive this. That's my point. And it's not belittling the people who've been sick. I've taken care of as many non-critically ill patients as almost as anyone in an outpatient setting. And we've doing all the follow-up care. I understand what's going on with this, but this is not the end of the world. And that's what I think is we're getting promulgated all the time, that the world's over. It will never be the same. We don't have, it's not true. It's just patently false.
The next two are ones that you've asked, but you've answered before.
I'll answer them differently.
Okay. After the vaccine, somebody got their antibodies test. It was a couple. One showed antibodies, the other didn't. And the doctor just said, well, you didn't have a strong reaction. What do they need to do?
Well, if you didn't have an antibody response after the second, if you measure your antibodies after 1 week after the second dose and they're not elevated, you need to see an immunologist and get your immune system checked. And I would recommend Amy Darter in Edmond. She has the right type of laboratory equipment to do that. I do have her permission to say that. She's busy, but she clearly would be very interested in understanding what is going on with your immune system if you don't make any antibodies after the vaccine. You should be very interested too, because we want to know what's going on with you and figuring out a plan, because you're the exception.
Well, would that matter which test they did to test the antibodies?
Well, I mean, the easy thing to do first would be to do a repeat with a different lab, and just to make sure. That would be very wise. I mean, we like the LabCorp SARS-2 COVID quantitative test, and so I would always recommend that one.
Okay.
Because it could be a false negative, there could be a lab error. But likewise, the other thing to keep in mind too is not all the vaccines are going to be given are going to be successful. There could be an injection error. The vaccine could have gotten too warm. Stuff happens. So that's why you have to. I think you want to question what happened. I wouldn't just assume you're immune if you don't have any antibodies when they should be off scale is the norm.
Okay, and then the last one is back to the vaccine doesn't keep you from infecting others. It just keeps you from getting as sick if you're exposed.
That's an error. The endpoint of the study was immunity. It's immunity. Yes, it does keep those who get sick, the small group who in the beginning who got sick, they have less intense disease. There have not been a lot of reports yet of the group, the intensity of the illness in the groups who didn't respond and who got sick. So let me rephrase that. The purpose of the vaccine was immunity. It wasn't to lessen disease intensity. So no, it's immune. It's immunity. It's not been, we've never been shooting for anything else. The trials were designed to truly detect vaccine absolute efficacy. And that's what they show, that there is a 94% reduction in getting the infection. It is not a 94% reduction in disease illness. It's in getting the infection, period, which means you can't spread the infection. And this idea that you can spread infections when you're immune to them is baloney, other than if someone just coughed on your hand who had COVID and then you had that someone else like you then touched a doorknob with that fresh, for lack of a better word, spittle on your hand, and then someone else touched that right after you did, picked up that spittle and then touched it. But that's not a vaccine failure. You're still immune. There's still vaccine. There's still going to be viral particles around for people to get for a while. But once we get to herd immunity, that all lessens.
That's it.
Okay, thanks. Good night.